My talk is entitled Assessing and Promoting Equity in VA Healthcare. Next slide, please. I have no competing conflicts of interest, and the views expressed are my own and not necessarily the position or policy of the VA or the US government. Next slide, please. Special patient populations in the VA are those that are at increased risk for health disparities. By health disparities, I'm referring to health disadvantages that are closely linked with social or economic disadvantage. Several of the demographic, social, and health characteristics of groups experiencing health disparities are listed on the slide here. Now, one of the earlier sessions focused on measuring access. A challenge of measuring access for special populations is in being able to systematically identify those groups within VA. We have a robust scientific literature on equity issues related to race, ethnicity, sex, rural geography, mental health disorders, and homelessness, and that's in part because we could identify those groups fairly comprehensively in the VA electronic health records. By contrast, there's significantly less robust literature on LGBTQ populations and religious minorities. Next slide, please. When we view access to care through an equity lens, we find that healthcare access barriers that systematically and negatively impact less advantaged groups contribute to health disparities. Next. Now, there are several myths about addressing disparities in health and healthcare access. I've heard people ask, hey, why not address healthcare access barriers by treating everyone in the same way? For example, with respect to race ethnicity, they suggest being colorblind as an approach to achieving health equity. That approach is problematic. Next slide. In this schematic, the purple bars represent different populations within VA, and the height of the bars represent the baseline level of health and resources available to those groups. Assume that there's some desired level of health that they or we are all trying to achieve. That's depicted by the dashed horizontal line. The different populations vary in their personal circumstances. That is, in the conditions in which they are born, grow, live, work, and age, or collectively, what we refer to as their social determinants of health. Therefore, as depicted by the differing heights of the bars, we see health disparities. Next, please. The yellow arrows depict healthcare delivery. Healthcare delivery begins with access. Treating all groups in the same way would result in special populations, those with less baseline health and resources, not achieving the desired health outcome. Next, please. Instead, what's required to achieve health equity is to tailor care to the social context and needs of each group. Within VA, we've looked at outcomes associated with generic versus tailored interventions. By generic interventions, I'm referring to access-focused quality improvement interventions that are implemented, but done so without specific tailoring to special populations. These interventions may improve outcomes on average, but they do not reduce disparities, and in fact, they are at risk in some instances for widening disparities. Tailored interventions, by contrast, such as the Digital Divide program that we heard about in an earlier session, are examples of equity-focused interventions that address access barriers experienced by special populations. Next, please. So health equity means that everyone has a fair and just opportunity to be as healthy as possible. Next, please. There are many frameworks of conceptualizing access to care. We heard about several of them yesterday. The elements of access conceptualized by Pinchansky provides a useful organizing framework for characterizing equity issues. This framework characterizes access as the fit between patients' needs and the system's ability to meet those needs. The elements are availability, which is demand compared to supply; accessibility, related to location and travel resources; accommodation, or the organization of care; affordability, which may be thought of as income compared to price; and acceptability, which is related to attitudes and culture. I'll give examples of each of these elements for VA special populations. Next, please. VA healthcare availability or volume of services must be considered separately by care delivery modality. These modalities being on-site care delivery, telehealth, either synchronous or asynchronous, and community care. Patient-centered availability issues that we've identified in VA research include lack of racial ethnic concordant healthcare providers for on-site medical and mental health care, and that's for racial ethnic minority veterans, and lack of gender concordant mental health providers for women in some settings. Many of these veterans prefer to receive care from VA providers rather than community care because the VA providers and the VA system have greater expertise for conditions associated with military service. So these lack of race or gender concordant providers in some settings presents an access barrier. Other studies have found that specialty care services were less widely available at some rural or smaller sites, and that's compared with availability at the larger, more urban sites. But these services were also not widely available in the community. Examples include specialized gynecology services in some rural areas. Now, it's also important to know that for some special populations, VA has helped to fill the healthcare availability gap. One example of that being dual users of VA and Indian health services. In many instances, the dual users of those services might receive their primary care through the Indian Health Service, but then seek VA care for specialty services and procedures. Next slide, please. With accessibility, we examine the spatial and geographic relationship between healthcare providers and VA users. For rural dwelling veterans, distance to services is a barrier, particularly when coupled with wintertime weather-related barriers. Increased distance was associated with decreased service use and to attrition from VA use. In urban areas, transportation difficulties are a barrier to healthcare use. For example, having to ride 2 to 3 public buses to get to VA care. Though telehealth may address some of these accessibility barriers, the digital divide or decreased access to the internet, computers, and smartphones for groups such as racial ethnic minorities and the elderly can reduce barriers. We examined telehealth use last year, so prior to the pandemic, and found racial ethnic disparities across many VA sites in telehealth use. Next slide. Accommodation is the organization and content of healthcare as it relates to the ease with which people can use care. VA routinely collects patient perceptions of selected access measures such as wait times for and at appointments. This data has revealed lower ratings for several vulnerable groups, including racial ethnic minorities, younger age groups, and groups with diagnosed serious mental illness or substance use disorder. Accommodation is also an issue for caregivers. There are sex differences in caregiving roles, with women much more likely to be caregivers for spouses, parents, children, and others. Caregiver burden wasn't identified as an access barrier for women veterans. Next slide. Affordability relates to both costs related to an individual's financial ability to obtain care and to patient perception of value. Financial barriers to healthcare are a greater issue outside VA. Among VA users, having lower income is associated with greater VA use, so greater reliance on VA, and in that sense, decrease access to services. However, it's also associated with delaying care and having greater unmet healthcare need. In the national survey, and that's actually, I should say, particularly important for those with mental health disorders. Another group it's important for are low-income people who may be employed in areas in which they don't have sick time off from work, which would allow them to get routine preventive care during usual daytime hours. In the National Survey of Women Veterans, we found an interaction between income and mental health disorders, such that women with both low income and mood disorders had greater unmet need. Next slide. Acceptability. Equity-related acceptability issues include the environment of care for women, gender and sexual minorities, and racial ethnic minorities. For example, a study published 3 to 4 years ago described harassment of women coming to the VA for care, and that led to a national VA initiative, Stop Harassment. Patient-provider communication and medical mistrust have been identified outside VA as barriers for racial ethnic minorities. There are several VA studies I can talk about in the discussion time that address this. Medical mistrust is another important barrier for VA users. We heard in an earlier session the statistic that 30% of veterans lack trust in VA providers, and that's a barrier. Next slide. So based on this framework, there are several actions we should consider to promote equity in VA healthcare access. To address availability and accessibility, we should assure diversity in the clinician workforce that's reflective of the population served, expand the digital divide program, that's particularly important given the greater reliance on telehealth, and we should examine other barriers to telehealth use, as well as expand after-hours access to primary and preventive care. Next slide. To address accommodation, we should systematically measure and address social determinants of health. Think of the Cerner transition. That is a great opportunity to incorporate more of these measures into the electronic health record. We should also expand use of evidence-based interventions, such as patient navigators, who can facilitate access and coordination of services. Next slide. And to address acceptability for measures of trust in VA healthcare and providers, VA should systematically assess and report patient ratings by special populations and monitor the environment of care by patient populations. Next slide. This is my last slide. Thanks for the opportunity to discuss equity in VA healthcare, and I'll turn it back over to Dr. Southpaw. Thank you.